All right. Good morning, everyone. My name is Reed Alley. I'm one of the first-year cardiology fellows, and thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our speaker Dr. Vig Kasirajan. Dr. Kasirajan is chair of the Department of Surgery. He specializes in cardiac surgery related to the treatment of adult heart disease. His focus includes valve surgery, complex coronary reconstruction, heart failure, artificial heart surgery, heart transplantation, cardiac arrhythmias, and ventricular assist devices. Currently, Dr. Kasirajan is principal investigator for an international multicenter study looking at hybrid minimally invasive surgery and catheter ablation to manage persistent atrial fibrillation. In 2006, Dr. Kasirajan led the first surgical team on the East Coast to implant the SynCardia total artificial heart at VCU Medical Center. We are grateful for Dr. Kasirajan's experience on his topic and look forward to learning from him. At the end of the lecture, we will have time for questions. Please submit questions via the via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Kasirajan.
Great, thank you so much for the kind introduction. I'm going to go ahead and share my screen. Okay, good. Can you all see my screen? Yeah, awesome. Well, thank you so much for having me and for the opportunity to talk a little bit about coronary artery disease, which is near and dear to my heart. So my disclosures are I have research grants to VCU from SynCardia, Abbott, AtriCure, and Abiomed and Carmat. Carmat currently is pioneering a new artificial heart that I'm the PI for the US national study. But more importantly, I have a couple of emotional disclosures. I became interested in cardiac surgery many years ago before I went to medical school. My father is a cardiologist. And was in the US training in the late 60s and 70s when cardiac surgery was coming into its heyday. So he was always talking about cardiac surgery. And when I first joined medical school, I had the opportunity to see a beating heart during an open heart surgery. And I decided that's the coolest thing I've ever seen. Decided to go into cardiac surgery. Now, fast forward now, my son recently decided he's going to become a cardiac surgeon, much to the chagrin of my wife, who's no OB-GYN. And my daughter just told us that she may be thinking about surgery. So there is some emotional disclosures. The other thing I want to, two important people made very significant contributions to my career here at VCU, and they're both cardiologists. One is George Vetrovic, who was the division chief and led the creation of the Pauley Heart Center. Without George, I wouldn't have succeeded, and he was instrumental in my career, along with Ken Ellenbogen, who really helped to develop my interest in cardiac arrhythmia and its further treatment. So thank you both. So I want to go a little bit into the history of coronary artery disease treatment from the 1970s. In 1968, the NHLBI at that time started a clinical trial. It was a multi-center trial in the VA hospitals looking at coronary surgery. But at that time, coronary surgery was a Weinberg procedure. So in 1968, the protocol included randomization to then medical therapy, which primarily included nitroglycerides and a few other drugs to treat blood pressure. There was no beta blockers, no ACE inhibitors, no ARBs, no statins, to the Weinberg procedure. Subsequently, in 1970, with the advent of modern coronary bypass surgery, primarily with saphenous vein grafting, developed by Rene Favalero at the Cleveland Clinic, along with the cardiac cath techniques developed by Mason Soames, they modified the protocol to include saphenous vein graft bypass to medical therapy at that time. What the VA study showed when the data was first published, 1970, they started enrolling 73, 74, the data was completed, published in 77. Essentially, what the study showed was that for patients with significant left main disease, angiographically defined at that time, looking at survival, mortality, there was no difference unless you had left main disease. If you exclude patients with left main disease and just look at patients with three vessel disease, whether you treat them medically or surgically, the survival was very similar. So this is first data from the VA randomized study in the 1970s. Then came the coronary artery surgery study, the CAS registry, that included patients with left main disease, triple vessel disease, who were initially treated with coronary bypass surgery and non-surgical therapy or medical therapy at that time. Remember, this was an era where PTCA at that point had just begun to emerge in the as a technique in the 1977. So when you look at CAS data, this is a 15-year cumulative survival estimates for patients undergoing coronary bypass surgery with medical therapy. There was a benefit, again, primarily in patients with significant, greater than 50% left main stenosis. There wasn't a significant difference if you looked at patients with three vessel disease, defined angiographically at that time, with symptomatic coronary artery disease, with surgery versus medical therapy. In 1986, the Cleveland Clinic first published this data. This is not randomized study, but it's a cohort follow-up patients who underwent coronary bypass surgery at the Cleveland Clinic, followed every year through a registry, looking at survival when they had a mammary graft to the LAD versus a saphenous vein graft. Between 1970 to probably well into the mid 80s, even to the 90s, the primary graft for the left anterior descending was a saphenous vein graft. There was data emerging from large centers such as the Cleveland Clinic, which had looked at, and the Mayo Clinic, looking at large cohorts of patients, that atherosclerosis of the vein graft of the LAD contributed to late cardiovascular events after 5 to 10 years. So this was a paper from Dr. Loop, which is a seminal paper, looking at the Cleveland Clinic data that showed that there is a benefit of using a left internal mammary artery over a saphenous vein graft in patients with three vessel disease. But if you look, the survival actually became more significant after 6 years. So you really start seeing a survival benefit of the left IMA to the left anterior descending in triple vessel disease at about 10 years. In this paper, they also looked at patients with single vessel disease, predominantly the LAD, who had bypassed with a left internal mammary versus a vein graft, and there was no difference in outcomes, even after 10 years. In two vessel disease, again, similarly. So really, the benefit appeared to be primarily in complex three vessel disease and left main disease, even with the use of left internal mammary to the left anterior descending. So at this point in the 90s, the use of a left internal mammary to the left anterior descending became a standard of care and was adopted by the Society of Thoracic Surgery as a guideline, and subsequently, even now by many payers, as a quality indicator for payment for coronary bypass surgery. So our current use of IMA to the LAD in coronary bypass surgery in the US is around 97.5%. Then in September 16, 1977, Andreas Grunsig developed coronary angioplasty in Switzerland. And this was a seminal event that revolutionized the treatment of coronary artery disease. I remember my father, as a cardiologist in the 1970s, was telling me that coronary bypass surgery would disappear because of this new technique. In fact, the first patient that Andreas Grunsig did an angioplasty on was just an angioplasty with no stents then. Lived over 15 years free from angina, and there was actually a 10-year angiographic study on him showing very minimal restenosis of the lesion. So what he said was very important, I think, and this is something to keep in mind. He said, no matter what happens to the technique, I have made one contribution, and that's allowing physicians to work within the coronary arteries of an awake patient. And this becomes important as you start looking at studies, starting to compare medical therapy to PCI and surgery. This was a mass medicine angioplasty, was a surgery trial that showed that with PTCA without stents, there was significant restenosis contributing to events happening after 1 year. Then you have the modern PCI era that developed in the 90s, late 90s and into the 2000s, where we started having advanced stenting technology that allowed us to handle coronary artery disease. Percutaneous interventions revolutionized the treatment of acute coronary syndromes. I was many years ago when I was lucky to have dinner one night with Rene Favalero, who was a visiting professor at the Cleveland Clinic, and I was talking to him and he said, what he told me was very important. He said, there are patients with severe angina. They used to admit them to a hotel right next to the Cleveland Clinic in the 60s and 70s. And when their angina got really worse, they would rush them into the OR and operate on them. And their mortality was very high because we did not have an ability to take patients rapidly to the cath lab and treat them percutaneously. The treatment of ST elevation, myocardial infarction, and other acute coronary syndromes with percutaneous intervention has saved unknown number of lives all over the world and has revolutionized the treatment of acute coronary syndromes and reduced the mortality and morbidity from it. But today's talk is not about acute coronary syndromes, but we're going to talk about stable ischemic heart disease. So these are patients who have not had an acute syndrome for at least most trials for 2 to 3 months and have angina and have significant ischemic burden and are managed medically. The first study that looked at in the modern era looking at stents was a Syntax trial, which compared patients with left main or 3-vessel disease with percutaneous intervention with modern stents, drug-eluting stents versus surgery. And if you look at the events that for cardiovascular, cerebrovascular events, major adverse cardiac and cerebrovascular events, MACCE, in patients, you can start seeing these with higher Syntax scores, CABG, which is in blue, and PCI in yellow. There is a divergence in outcomes. But I want you to focus on the lower Syntax scores. If you look at patients even with 3-vessel disease, and interestingly left main disease, you see that PCI, there is a higher event rate with CABG compared to PCI with lower Syntax scores. And I think this is important in many ways to understand a little bit more. And this is very important for cardiac surgeons when we make decisions about when we operate on patients with coronary artery disease. So for example, if you have a left main that's 8-10 millimeters and there's 50% stenosis, that may be angiographically significant. The flow through that vessel, unless it's very complex and tortuous with bifurcation lesions, is quite significant. So when you put arterial conduits to a vessel with that degree of flow, the coronary bypass grafts shut down because of competing flow. And that's why in many trials, when we look at 50% left main or even 50% proximal left anterior descending disease, which may be significant even by FFR, an arterial graft may not stay open because these grafts are not meant to stay open against competing flows at that level. Many of these vessels we take for coronary bypass grafting, including the left internal mammary or the right internal mammary or the radial artery, change according to competing collateral circulation through the chest wall or the arm. So when you put them into a coronary, which has significant competing flow, they still think they are in the chest wall or in the arm. They don't, radial grafts don't know where they are. So they will spasm or shut down. And that may be the reason why in lower Syntax scores, you seem to have a higher event rate for coronary bypass surgery versus PCI. Whereas when you take complex disease, the curves diverge quite significantly early on. Again, looking at Syntax at 5 years, looking at repeat revascularization. The revascularization was primarily higher in the PCI group and related to the target vessel and seemed to be done mostly for symptoms. However, the need for repeat revascularization was related to higher major adverse cardiac cerebrovascular events and mortality. So there was, and particularly this became much more obvious in patients with higher Syntax scores, scores above 32, 33. If you look at, but mortality and events may not be the only thing. So if you look at quality of life measured here by the Seattle Angina Questionnaire, health status after PCI versus surgery at 5 years, you can see that, interestingly, so surgery is in blue. So if you look at this column here, this graph here, you can see surgery has physical limitations for up to 12 months. And I want people to think about this a little bit. Yeah. Open heart surgery, even if it's minimally invasive, cardiopulmonary bypass, the recovery takes many months to occur. So there is a significant physical limitation to cardiac surgery, at least early on, even if there is a late benefit in terms of recurrent events. If you look at diabetic patients in Syntax at 5 years, 5-year rates were significantly higher for PCI compared to CABG for major adverse cardiac and cerebrovascular events and repeat revascularization. So there is a signal with diabetics. The FREEDOM trial that looked at diabetic patients undergoing PCI versus surgery, again, you can see here, there is a death, myocardial infarction, or stroke. There is a benefit for CABG over PCI. But look at the early signal here. CABGs do have a slightly higher increased risk of stroke and perioperative myocardial infarction. So it is very important in the context of complex coronary vascularization or cardiac surgery to keep the complication rates as low as possible. The current STS recommendations for mortality for coronary bypass surgery is less than 2%, is what we have been recommended by the National Society to achieve at every center, no matter what the patient population is. Stitches, which is a surgical treatment for ischemic cardiomyopathy, extended survival study comparing medical therapy versus coronary bypass grafting for patients EF less than 35%, again showed that primarily after 6 years, close to 10, 15 years after randomization, there was a benefit for coronary bypass surgery compared to medical therapy. But again, if you look at the complication rate, event rate, you see how early after surgery, there's a slight increase in event rate compared to medical therapy in the early era. Again, indicating the importance of careful conduct of surgery and patient selection. The Noble trial, the Nordic trial looking at bioluminescent stents versus CABG for left main and multivessel disease. This was a follow-up to 5 years, showed that CABG had a lower major adverse event compared to PCI, but all-cause mortality was very similar. The Noble outcomes stratified by Syntax score, again showed CABG was better for, these were patients primarily with complex disease. There was a benefit across all scores. Excel trial, which is a primarily a US trial looking at everolimus eluting stent compared to CABG for left main and multivessel disease. Again, here, so there's a little difference between these two trials. They're both looking at left main disease, but the Excel, the outcomes were reported at 3 years and at that time, and then the Noble reported it to 5 years. So you can see that the curves are fairly flat, but when you look at the death from any cause, there is a slight divergence. Now, the death from stroke, myocardial infarction, again, you can see after CABG, there is an early event rate that peaks up and then the curves flatten out. So if we can lower the complication rate for coronary bypass surgery very early, there may be some benefit to survival in this and with longer term follow-up. Again, in the Excel, the Seattle Angina Questionnaire, look at the top right, the physical limitation after coronary bypass surgery, which is in red, was significant up to 12 months. So that is an important factor to keep in consideration. Now, Courage was a trial looking at PCI versus optimal medical therapy in non-left main disease. We look at multivessel disease. Again, PCI did not seem to have a significant advantage or optimal medical therapy in patients with stable ischemic heart disease. There was no surgery arm in this trial. So what do we know now? So fast forwarding from 1970s to today, there have been significant advances in medical therapy, including preventive cardiology, advances in lipid management, and medical therapy to target hypertension, diabetes, lifestyle changes, including smoking cessation, weight loss, exercise. Significant advances in medical therapy. We do know that diabetics have a higher plaque burden in the epicardial coronary arteries, but they also have significant changes to their microcirculation that will have an impact on how we revascularize them or whether revascularization is possible. I also want to point out an important difference between PCI and CABG. We often compare percutaneous intervention to cardiac coronary bypass surgery, but they are not exactly the same. PCI targets the most diseased part of the vessel and opens the vessel up to allow more blood flow through that stenosed area. CABG, we try to find the least diseased part of the vessel and bypass it. So it's almost like an extensive collateral circulation is what we create with bypass surgery rather than targeting the most diseased part of the vessel. So I don't know if truly these are comparable in some ways as opposed to being complementary therapies. So what is our current knowledge of who benefits from coronary bypass surgery? Patients with left main disease, particularly complex left main disease, over 70% bifurcation, trifurcation lesions. Complex lesions with syntax score above 32, 33. Diabetic patients with EF less than 35% favor CABG. PCI is equivalent in moderate complexity disease, including left main disease. Optimal medical therapy is the foundation on which we should build all revascularization strategies, beta blockades, statins, modern antiplatelet therapy, renin-angiotensin system modulating drugs, optimal management of diabetes. The current recommendations before revascularization is a hemoglobin A1C less than 8, less than 7.5 if they can avoid hyperglycemic events in these patients. Weight loss, smoking cessation, exercise, cardiac rehab. These things are critical before we embark on revascularization, whether PCI or medical or surgery in patients with stable ischemic heart disease. So I want to spend a little bit of time on the trial that came out in 2020, was published in 2020, looking at a strategy of initially invasive or conservative strategy for stable coronary artery disease. Why this trial is important and different is that in all trials, like including Syntax, the Excel Noble and other trials, FAME that was recently looking at FFR before ischemic revascularization, ischemic territories, and other trials comparing surgery or PCI to medical therapy, they all started off with an initial angiographic evaluation and then looking at the anatomy to decide if these patients should undergo one therapy or the other. With ischemia, the trial design was a little bit different. So there was an exclusion criteria. So if the GFR is less than 30 ml per minute per 1.7 meter square, primarily out of concern because these patients had to undergo CTA, and we'll talk about that a little bit. So the GFR was an exclusion. There was a separate arm for ischemia called ischemia chronic kidney disease that was published separately. Any acute coronary syndrome within 2 months were exclusion. Unprotected left main greater than 50% was an exclusion. So left main disease was an exclusion from ischemia. New York heart, ejection fraction less than 35%, New York Heart Association class 3 or 4, or worsening angina with optimal medical therapy with exclusions for the ischemia trial. So it's very important to understand the patient population. So anybody with stable ischemic heart disease who had angina and above the age of, I think it was 21, were enrolled in the clinical trial. The goal was to actually randomize 8,000 patients initially, but however, the study enrollment was slow and they could not enroll 8,000 patients. So the study design was changed a little bit. Ultimately, about 5,000 patients underwent randomization. The primary endpoint was a composite of cardiovascular death, non-fatal myocardial infarction, hospitalization for unstable angina, hospitalization for heart failure, or cardiac arrest, from which the patient was resuscitated. Secondary major endpoints were composite cardiovascular death, non-fatal myocardial infarction, and quality of life, looking at the Seattle Angina Questionnaire. So what happened to all these patients is that they actually all underwent optimal medical therapy, and there was very strict guidelines on what the criteria the patient should meet for optimal medical therapy in terms of beta blockade, ACE inhibitors, blood pressure management, diabetes management, lipid management, antiplatelet therapy before, and they would have to have angina. So there was optimal medical therapy in both groups. And then the conservative strategy only had a cath if they had suspected event or refractory angina. Patients on the invasive strategy underwent cardiac cath within 30 days of randomization. Now, all patients initially underwent a non-invasive testing, and that's where the ischemia trial is different. So every patient underwent non-invasive testing to define moderate to severe ischemia. The non-invasive testing was either by radionucleotide studies or echo. I'm not exactly sure how many patients had MRI, but they also subsequently added exercise testing without imaging to account for centers that did not have that ability, because this was over 300 sites internationally. But they had very strict criteria for all the non-invasive testing. So all patients underwent non-invasive testing and should have at least 10% of myocardium at risk for ischemia. So they were moderate to severe ischemia, determined by the site, but ultimately adjudicated by the core lab. Then the patients underwent a CT coronary angiogram to exclude patients with significant left main disease. Then they were randomized to invasive strategy versus conservative strategy. So that's the difference in this study, is that this was not randomization after initial angiographic study to define the coronary anatomy. Now, if you look at, again, the outcomes from the study, the conservative strategy versus invasive strategy up to 5 years for the composite endpoint did not show a significant difference. You can see the invasive strategy increased incidence of the events in the composite outcome in the first year. And if you look at death from cardiovascular cause of myocardial infarction, again, there's a slight increase in events in the first year in the invasive strategy. If you look at the definitions of the myocardial infarction, they use the international harmonization for the myocardial infarction guidelines. And they counted peri-procedural raise in troponin or CK. CKMB was a preferred methodology for that as a definition for MI. But what we realized from the study is that a peri-procedural increase in enzymes is not the same as a spontaneous myocardial infarction with a rise in enzymes. So if you actually, there were further papers published looking at removing those definitions, and then you can see that the initial outcomes seem to be much more equivalent for invasive strategy versus conservative strategy. So if you look at D, where we look at myocardial infarction, you can see a signal again in the first year, primarily related to peri-procedural events. So this led to the ACC AHA SKY guideline for coronary vascularization. Now, this was a very comprehensive document talking about coronary vascularization across the spectrum of coronary artery disease, including acute syndromes and other conditions. I picked out the group, the sub group that looked at the recommendations related to stable coronary artery disease. So essentially what they said is that if patients stable ischemic heart disease, revascularization is indicated primarily for patients with refractory angina and medical therapy. So even if you look at ischemia trial, when they're randomized to both the conservative strategy, which is optimal medical therapy, versus revascularization, which is optimal medical therapy, then revascularization. 21% or so patients in the conservative arm failed optimal medical therapy and then underwent revascularization, either PCI or surgery. In the ischemia trial, the choice of whether the revascularization should be PCI or surgery was left to the local sites. In the invasive strategy, about 40% or so patients underwent PCI and 21% underwent CABG. And if you carefully read through the paper and talk to the authors, one of the things that came out of that was a lot of that is related to patient preference for having PCI versus surgery and because of the invasiveness of surgical technique. The other thing that about the ischemia trial that's very important is that the sites were very carefully chosen based on operative experience, both for PCI and for cardiac surgery. And every site had to have a heart team, which is comprised of a cardiac surgeon, interventional cardiologist, a primary cardiologist, or an internist to help to make decisions with the patient. So that was a very important part of the decision-making in the trial. The criteria for selecting patients for the operator, the cardiologist for doing PCI was that the site should perform at least 400 primary PCIs, and each PCI, the interventional cardiologist should have done at least 100 to 125, I think, percutaneous interventions for non-STEMIs in a year, which is a significant volume. For cardiac surgery, the volume was, I think, 400 CABGs per year and 125 CABGs per surgeon per year, or 750 in a lifetime for CABG total volume. So these were very experienced centers with experienced cardiologists and surgeons performing these procedures. So the guidelines basically from stable ischemic heart disease, guidelines from the ACC SKY guideline basically said, if you have left main disease, significant anatomical complexity, if you're suitable for CABG, it's a class 1 indication to have a CABG. Where it became more controversial is that if patients don't have significant left main disease and they have 3-vessel disease with preserved EF, the indication for CABG was downgraded from 1 to, I think, 2A and 2B indications. And that's where there was a lot of controversy from the Society of Thoracic Surgery and American Association of Thoracic Surgery in terms of the guidelines. But I think if you read through the literature carefully, I would suggest that those recommendations are in fact quite accurate. But really what came out of the guidelines, I think was more important than just the recommendation whether you should have PCI or CABG. It was this concept of shared decision-making. And I thought this was simply the single most important recommendation that came out of that. Was a class 1 indication. In patients undergoing revascularization, decisions should be patient-centered. That is, considerate of the patient's preferences, goals, cultural beliefs, health literacy, social determinants of health, made in collaboration with the patient support system. I thought that was a very important statement. Because if you look at ischemia trial, the decision was very, so the trial was very much against performing PCI or anything with the initial angiogram. So when even in the revascularization arm, when patients underwent coronary angiography, the decision to then intervene either with PCI or cardiac surgery was deferred after the initial study was done and discussion was had with the patient and the team. Then the decision was made which way to go. And I think this was a very important concept that came out of it, is this thought about informed consent and how we do it and why it's important. So really, if you think about this, what is the team? The patient is the leader of the team. We are here to take care of our patients. So what favors CABG today? Patients with complex left main disease, particularly over 70%, diabetes, complex lesions with a high syntax score, younger age. That doesn't mean, as I get older, the definition of younger age changes. Patients with good life expectancy, EF less than 35%, low Society of Thoracic Surgery risk score for coronary bypass grafting. What favors PCI is lower anatomical score, preserved ejection fraction, and other comorbid conditions such as lower pulmonary function, patient on home oxygen, lower life expectancy, not simply based on age, but based on comorbid conditions, including frailty. The STS score, which is a very important predictor, and that was also a recommendation in the guidelines, was that the STS score be used to define the risk of coronary bypass surgery, does not take into account a number of factors. It doesn't take into account patient frailty, nor does it take into account conditions such as cirrhosis of the liver. So you have to be careful about how you make decisions and who you're going to operate on. So if there's a higher predictive operative mortality or a frail patient, the PCI may benefit them. Because if you look at all the studies, the advantage of coronary bypass surgery over PCI doesn't often become obvious beyond till you pass 3 to 5 year mark. So you really have to have a heart team working with the patient. Again, based on local resource availability, operator skill, patients' wishes, and optimal medical therapy. So just going back a little bit to optimal medical therapy before I jump to the coronary, a little bit about arterial grafting. So my takeaway from this, what I took away from all these studies is that when you have patients with stable ischemic heart disease, even if they have angina daily, if somebody comes to your clinic and they have a hemoglobin A1C of 12, I think it's very important to stop, optimize the glucose management, get the blood pressure under control, make sure they appropriate therapy before we proceed with coronary bypass surgery. I've now managed patients with good diabetic management for almost a year before we consider surgery to get the hemoglobin A1C down to below 8. That significantly improves the perioperative outcomes. And we follow these patients very carefully. We can see them in the clinic every week, every month, between us and our diabetic colleagues to get the A1C under control, get hypertension under control. Hypertension is a major risk factor for stroke during coronary bypass surgery. If somebody comes to a clinic with angina with a blood pressure of 180 by 90, it is perhaps best to stop, optimize the blood pressure control before we consider coronary bypass surgery or PCI. So I think that was my significant comfort looking at the stable ischemic heart guidelines in proceeding with revascularization therapy. Because often these patients are not on optimal medical therapy, surprisingly. They're not on beta blockade for some reason or the other. It may be patient preference, but I think we need to work through those things carefully, make sure the lipid management is appropriate, work with our cardiology colleagues and our primary care physicians to make sure those are optimized. Now, what do we know about now going into the cardiac surgery mode? So if we decide to perform coronary bypass surgery, what does modern coronary bypass surgery look like? Now, remember when you look at the VA study, the 1970s, cardiac surgery was very different then. We did not have myocardial protection with cardioplegia. These patients were operated on by intermittent cross-clamping and ventricular fibrillation. So you clamp the aorta, stop the blood flow to the coronary, fibrillate the heart, and rapidly sew the vein graft to the thing, take the clamp off, reperfuse the heart for 10 minutes, reclamp again, fibrillate the heart, do another bypass. So these were the techniques used in the 70s. Their operative mortality for multivessel grafting in the VA cooperative study was 5.6%. In the left main subgroup, in the first 2 years of the study, the mortality was 25% for CABG. So that's changed significantly in the last few years with modern myocardial management and cardiopulmonary bypass management, blood conservation, other things. So our expected mortality for CABG should be low. The use of the left internal mammary to the left anterior descending has now become guideline and is a quality measure. So it'll be unlikely that we can do randomized studies looking at non-use of IMA to the LAD. So that I think is pretty much standard right now. And almost 98% of patients undergoing bypass surgery in the US today have Lima to the LAD. Now, what about conduits to the other arteries? And that's where it becomes a little bit more challenging. If you look at the Society of Thoracic Surgery database, that is over 5 million patients over the last many years accumulated and followed, the current use of bilateral IMAs is less than 10% in the United States, 10%. And in most centers, it's less than 5%. The use of radial artery and multi-arterial grafting is even lower. So where are we optimized in terms of coronary bypass surgery? No, I don't think we are. Saphenous vein grafts are not poor conduits, they're good conduits, but significant atherosclerosis can develop in saphenous vein grafts after 5 years. We published a VA study looking at saphenous vein graft versus radial artery patency, and the patency of a saphenous graft at 1 year is around 80%. So this is a study looking at over 1 million patients who underwent isolated CABG. This is not a randomized study. This is just a follow-up based on the STS and NCDR, as well as the National Death Registry. At 10 years, multi-arterial CABG associated with the 10-year survival improvement. But again, I want you to focus on the time it takes to show benefits of survival of multi-arterial grafting. It's beyond 6 years. And this was a paper from Dr. Lytle published in early 2000s from the Cleveland Clinic, again, looking at a cohort of patients followed there over decades, that bilateral internal mammary artery survival at 20 years was significant for patients. Now, if you look at this, there are a couple of takeaways that are very important, because the first thing people are going to say is that, oh, older patients don't need bilateral arterial grafting or complete arterial revascularization because their survival is low. That is not accurate, because this is not cardiovascular survival or cardiovascular death due to cardiovascular causes. This is all event survival. So if you take somebody who's 80 years old and you give them a vein graft and a single mammary, it is my opinion, and this is not supported by data, is the quality of the vein grafts in older patients, particularly in women, is often substandard. So you actually do a disservice to them. We looked at the VCU experience and we published it on female gender and coronary bypass surgery. Across all groups, women did worse after coronary bypass surgery in our institution. This was published in probably in the mid-2000s. And one of the things when I looked at the data very carefully is that older women tended to get more venous conduits. But we do know, at least for cardiac surgeons, in women, particularly in women who are older, the quality of vein grafts in the lower extremities is often not optimal. There are differences even between vein grafts taken from the thigh versus below the knee. So do those play a factor in long-term outcomes in women, particularly women or older patients, is important. So what I want you to look at here is that this is 20-year survival. So if you look at 10 years, even in patients above the age of 70 or above, there is a significant advantage to using arterial conduits compared to a single conduit to the LAD. Now, if you take patients with very significant comorbidities, with a very low EF, severe lung disease, advanced heart failure, there may not be a significant benefit for multi-arterial grafting. So we have to be careful about the recommendation saying that, well, you have to operate on patients. CABG is better for patients with low EF versus patients with significant comorbidities. And it takes a long time to show the benefits of the CABG, and then with optimal arterial conduits beyond 10 years. So if you go, so I just want to look at a couple of patients. So here's a patient that underwent angiography here, maybe playing slowly, but let's see if we can move it forward. So this is significant coronary artery disease. So an 84-year-old male with complex CKD, complex three-vessel disease. EF was initially 30%, improved to about 50% with good medical therapy. Decided he doesn't want anything done, wanted to just stay on medical therapy. What continued to have worsening angina? What would you do? So Dr. Lawson was a cardiologist, we both talked, and we said, he probably should have coronary bypass surgery, given the fact that this patient was actually quite highly functional. He was working out every day, walking 5 miles, physically very active, not frail. But the patient said, I don't want any surgery. I just leave me alone. I want to take medical therapy. I'll be fine. He continued to have worsening angina and ultimately underwent PCI of his complex coronary anatomy with good outcome and is currently angina-free and doing quite well. So again, this just underscores the importance of a patient involved in the decision-making process before we decide what to do. Now, here's a patient who had an acute syndrome 3 months ago. EF dropped to 20% during that time, was treated with optimal medical therapy. EF definitely improved, not a diabetic, was told that he's not a candidate for any PCI or any surgical intervention due to his age, was advised to, basically have goals for end of life care. But he's 90, but he's not 90. So I saw that. So his primary care physician called me and said, Vig, it looks kind of odd when I call you about a 90-year-old patient, but I want you to actually see the guy. So when I saw him in the clinic, he's lifting 25 pounds in each arm, 100 reps on each arm with 25 pounds. He squats with 50 pounds 100 times every morning. He's running a mile a day or more with this coronary anatomy with optimal medical therapy. And this guy looked very fit. So the question was, should we do a cabbage on him with left main disease and diffuse coronary and more complex coronary disease? But when we did the STS risk stratification, a couple of things came out. He had a right carotid endarterectomy and has an occluded left carotid. So we got a CT of his chest that showed significant atherosclerosis of the aortic arch that put him at a very high risk for stroke and a high STS risk for coronary bypass surgery. So we instead offered him stenting, from which he has done well and is many months out and is doing quite well. So again, it underscores the importance of a team to make a decision about what is optimal for the individual patient. So 72-year-old female, left main disease, 40–50%, very complex proximal left anterior descending disease, distal circ, very complex proximal, tortuous proximal RCA, EF 50%, heavily calcified aorta. Calcified like a pipe. Optimal, she presented actually initially with heart failure, low EF, improved with good medical therapy, was seen at 2 institutions, turned down for PCI as well as for surgery, and subsequently was continuing to have worsening angina. The primary care physician called us, we saw her. We felt that her anatomy was not really suitable for PCI given the amount of calcification, left main disease, as well as LAD. What do you do? So we then offered her coronary bypass surgery, but with beating heart, off pump, no coronary, no touch of the aorta, bilateral internal mammary in situ to the LAD and the RCA. And later, if she needs it, now she has got a protected left main that we can handle if necessary with PCI. So this was, again, a decision that took many weeks to make with careful discussion with patients, our providers, and our interventional pathologists. I think that was the end of my presentation. Shannon, am I supposed to go over the MOC now?
No, you don't have to go over it. I think if you want to stop.
I just put it in here.
Screen.
Yeah, so we can stop here and then I'll take any questions. Yeah, and I'll stop sharing and take any questions. And I do want to thank the Pauley Heart Center with Greg's leadership. VCU has been an awesome place to work. I've been here 23 years. All my colleagues in cardiology, cardiac surgery, the entire team, nurses, perfusionists, everybody has played a tremendous role in the success of this program. And I want to thank you all for the opportunity to be here.
Vig, thanks so much. Before Reed gets to the questions, I wanted to jump in with one. So we have a patient with stable ischemic heart disease, but they have a very low EF. Their EF is now 20%. Could you walk us through your decision-making process as to, and they have multivessel disease, as to whether or not to proceed with coronary artery bypass grafting? And then is there any role for any kind of viability testing?
Yeah, so that's a good question. So when we look at, as a cardiac surgeon, when I look at patients with low ejection fraction, there are 2 things I look at. One is I look at the size of the ventricle. If the EF is low, but the ventricle is relatively small, less than 6 centimeters, it is usually they're ischemic and they have a low EF. If they have a very dilated ventricle, with the ventricle around 8 centimeters, 8.5 centimeters, and the coronary artery disease is present, but it's more moderate. You have 50% left main, 60–70% LAD, maybe a 50% circ, RCA disease. They are often incidental coronary disease unrelated to the dilated cardiomyopathy that may have other causes. So for most patients, we would revascularize with low EF, would have very complex left main, proximal LAD disease, circ, and CT or the RCA, with EF not 20%. Surprisingly, with medical therapy, the EF will actually improve slightly in these patients. And that actually indicates an opportunity that they would benefit from CABG. There was some signals from the Stitch trial that that was indeed the case. So in fact, in the Stitch trial, and this was a subgroup, an ad hoc after the fact analysis of looking at myocardial viability. In that subgroup analysis for the Stitch trial, and the myocardial viability determination was very varied, and MRI was not used in all the patients. Patients with significant myocardial viability actually did really well on medical therapy compared to those with no viability on medical therapy. Whereas surgical patients, it didn't seem to make a difference what the viability study showed. Now, keep in mind that this was done, many years ago, and MRI and more sophisticated techniques were not used on viability studies. I do think there is a benefit for viability studies, but however, often my decision making is based on two things: the true complexity of coronary artery disease, size of the ventricle, and then we would and usually if they have significant angina symptoms or shortness of breath, not advanced heart failure. Now, if they're present primarily with heart failure, I think viability to determine whether there will be benefit of revascularization may be indicated. But I don't know if we have had studies randomizing patients to look at those subgroups of patients.
Thank you, Vig.
Thanks very much, Dr. Kasirajan. This is an excellent overview of stable ischemic heart disease. We do have a couple questions coming in. I think Dr. Aaron Schatz has his hand raised, so I'll start with him if he wants to unmute and ask his question, but I also have a few in the chat as well.
Hey, Dr. Kasirajan, thanks so much. That was an excellent presentation. My question to you is there a lesion or a degree of a lesion where you're looking at it and saying, I don't want to wait for medical therapy on this lesion. This looks like something, if I had, I would want to take care of sooner rather than later?
Yes, I think that's a good question. So let me give you an example of a patient. So about a year and a half ago, I saw a patient with fairly complex left main trifurcation disease with the CTO of the RCA having significant angina. She was having angina every day. And the anatomy was very worrisome, right? But when I saw the patient, her hemoglobin A1C was close to 13. Her hemoglobin was 12. So in general, if your hemoglobin A1C is greater than your hemoglobin, it's not a good idea. So we were very concerned about operating on her because we're almost certain her sternal wound won't heal. Her BMI was 40. And she had no therapy for diabetes. So we made a decision at that point not to offer her surgery, but really get her hemoglobin A1C and diabetes under control. And it took us a year and a half to get it under control for various reasons. She couldn't afford the insulin. So we had to kind of work through social support service to get her insulin. A year and a half later, her hemoglobin A1C was 7. She had about 10-pound weight loss. She was actually walking, feeling better. She was still having angina, but not to the frequency at which she was having before the hemoglobin A1C diabetes was controlled. So I do think if they are stable, if medical therapy is not optimized, I think the angina symptoms may be related to significant microvascular disease that we can't see by just looking at epicardial coronaries. And I think it's important for us to pause, because even with PCI or definitely with surgery, wound healing is so poor that our morbidity and mortality with external dehiscence is significant.
Thank you. I appreciate that.
Speaking of microangiopathy, Dr. Powell had a question. He said, great talk. For microangiopathic coronary artery disease, is there a role of TMLR or transmyocardial laser revascularization? Is it more effective in relieving symptoms than medical therapy?
I think transmyocardial laser revascularization has kind of fallen out. In fact, currently, we don't have anybody. The company that was making the YAG laser for TMR is no longer doing it. I believe there may be a CO2 laser that's available, very limited resource. So the initial study showed some benefit in possibly angina improvement. But I think today the data is that just with good medical therapy, you will get better outcomes than with tumor loss. So today we don't perform that. We no longer have it available at VCU since we no longer have the ability to get the YAG laser and the supplies to perform it.
And Dr. Mohammed Peer, he has 2 questions. So I'll start with the first. He says, great talk. Thank you, Dr. Kasirajan. What is the physiologic mechanism that makes IMA relatively free of atherosclerotic process compared to other arteries, even in patients with otherwise severe peripheral vascular disease and coronary artery disease?
I don't know the answer to it. There's a lot of people have looked at this, looked at anatomy, looked at nitric oxide release from endothelium of the IMA. There are many things postulated. But I do think the concept that IMA is free from atherosclerotic disease is not true. We have had patients with significant atherosclerosis with IMA is actually diseased. So we have to be careful. The other thing to keep in mind is that the IMA may be relatively free from disease, but the subclavian artery could be significantly stenosed. So a simple thing in the clinic, such as measuring blood pressure in both arms, is critically important. Because often we would find a 30, 40 millimeter difference in blood pressure in the left arm compared to the right, or the right versus left. So then if you get a CTA looking at the subclavian artery, it's significantly stenosed. And in those patients, if you use an IMA to the LAD, you'll get a steal from either the vertebral or the arm, and could lead to either a dizziness, stroke-like symptoms, or chest pain when they start exercising. So I think there's lots of factors to be considered. But in general, the IMAs are much better compared to like the radial artery in terms of atherosclerotic disease. Now, the second question was on hybrid CABG versus a PCI approach to LAD and stenting the rest of the vessels. I think they're all options that we should keep for patients that may benefit from that. So, for example, somebody like that lady I showed with significant atherosclerosis or calcification of the aorta, where you cannot clamp the aorta or go on bypass, if the anatomy is suitable, would be ideal for off-pump lemur to the LAD and a stent to the RCA or the CERC. So I think there are options, and these are all options that we should keep for all selected patients.
Great, thank you. A question that I had, Dr. Kasirajan, I'm glad you spent some time talking about the heart teams and their importance at these medical centers. And actually, my first exposure as a fellow was our heart team approach at our VA Medical Center here in Richmond, and really a robust structure that they have. Your vision for the future, or your anticipation with the aging population that we mentioned that are otherwise quite robust and maybe not on paper the best surgical candidates, do you think that the heart team is going to become more and more prevalent, play a bigger role? I mean, I know our VA heart team meets once a week. With the increasing numbers of aging population, do you think maybe this is like a twice a week type meeting, just with how high volume patients that we have in this demographic?
Yeah, so I think there are multiple ways to do it. So I actually called many of the investigators on the ischemia trial and asked them, hey, how do you do that? How do you do it? Because the volume of patients coming in for cath and revascularization is significant. So, or studies, how do you determine? So I think there are probably multiple ways, right? So there are some patients in whom, for example, you may cath and say, hey, this is complex left main traffication disease, heavily calcified. 75-year-old with no other comorbidities, I would refer for CABG, and the decision is fairly straightforward, right? Then there are some that we cath and there's no significant disease and they have significant angina, you treat medically, and they don't have a benefit for revascularization. Then there is a group where the decision making is more complex, like the patient that you talked about. And there often, what we do is we talk to the cardiologist, we talk to the primary care physician, we see the patient, talk to the patient, and then we do it. Now, I think having at least once a week, look at the films to talk about, hey, what do you think about this? Is this an opportunity? Is this something we could do with some information about the patient would be very helpful? And I also think having maybe a joint clinic where some very complex patients where decision-making is complicated get referred in, so a cardiac surgeon and cardiologist can potentially see them at the same time. It may be a small minority of patients, would be beneficial in centers as we move forward. That's what most large centers are doing. It's not for us to look at 100 angiograms a week would probably not be feasible. So we'll have to somehow triage, which is what we do here.
Great. That's a really interesting approach as well. And then I think we have time for one final question. Dr. Joven at RVA asks, what is your approach in patients with ESRD and fistula on the left side who need CABG? Do you use the lima?
Yes. So in patients with advanced kidney disease, if they need a CABG and anatomy is suitable, we would use a lima or the LID, even in the presence of fistula on the left arm. The risk of steal is very low in the absence of subclavian stenosis. So the main thing to exclude in those patients is the presence of subclavian artery stenosis. Patients with severe kidney disease, particularly on dialysis or needing transplant, often have very poor venous conduits, and radial artery conduits are not usable. So the best conduits in these patients are bilateral mammary arteries. Our preference on these patients use bilateral IMAs after excluding the presence of subclavian stenosis.
Excellent. Thank you so much, Dr. Kasirajan. This, it's 8:30, so I think we'll go ahead and conclude here, but I just wanted to, on my behalf, thank you for this excellent talk. It was really a great morning conversation.
Thank you so much. Appreciate that.
Thanks so much, Vig. It's outstanding.
Thank you.